called Scarring and Stricture of the biliary tree. Let's take a look at an example of some stricturing that happens. We're going to look at this endoscopic retrograde cholangiopancreatography that is a type of radiographic study in which we inject the biliary tree with a radiopaque dye. The dye flows retrograde up the biliary tree, and you can see all the different areas that are dilated and stricture. So let's first take a look at a normal biliary tree. Here's the biliary tree. It's been injected with this radiopaque dye. We got the duodenal sweep over here. That's the sweep. Usually you take an endoscope and you stick a catheter in the ampulla and you push in some of this dye and it flows retrograde. Here you can see the main pancreatic duct. Over here you can see the common bile duct, and of course in the background you can see the biliary tree in the liver. If you look at the biliary tree, you can see everything is of normal caliber. There's no stricturing to be seen. Everything should be flowing very nicely through this biliary tree. However, here's an example of someone with primary sclerosing cholangitis. Something very similar occurs with acute cholangitis. And again, you can see this is the endoscope right here that's used to inject the tree. We've got some retrograde flow of the dye here going back into the biliary tree. You can clearly see that we do have a strictured area in the biliary tree. Proximal to the strictured area, you can see is dilated. Okay. Everything else in the tree, although it's dilated, doesn't look damaged, but there is that kind of focal strictured area. This happens to be an example of primary sclerosing cholangitis, but the same thing can happen with acute cholangitis. Primary sclerosing cholangitis is a autoimmune disease. Of course, acute cholangitis is an infectious disease. Let's talk a little bit about some of the presenting features. Okay, so again, you have colonization organisms, usually gram-negative. Something happens where the bacteria would get in here, ascend the tree, incite inflammation. This is called scarring. Could result in a stricture very similar to what you see here. Presentation, Charcot's triad, right upper quadrant pain. Okay, so that's pretty reasonable. You're going to have inflammation of the biliary tree, you'd expect that. Jaundice, perhaps bile can't flow properly through here. What kind of jaundice would it be? What kind of hyperbilirubinemia would it be? Conjugated hyperbilirubinemia causing this jaundice. Fever, naturally, because it's a significant infection. That may progress to Reynolds pentat, excuse me. The infection could cause septic shock and, of course, altered mental status. So all of these signs and symptoms are not too surprising when you consider it's an infection and it's potentially obstructing the flow of bile in the biliary tree. So the workup, labs, we'd expect a leukocytosis with a left shift. Hyperbilirubinemia, we said that would be a conjugated hyperbilirubinemia. Alk phos, do you know about alk phos? You have talked about alkaline phosphatase. So tell me what you know about alkaline phosphatase.
Something's breaking down bone.
Something's breaking down bone. Okay, so there are two isoforms of alk phos. You learned about the bone form of alk phos. There's another isoform of alk phos, comes from the liver. Specifically, it comes from the epithelial cells that line the biliary tree. If the biliary tree is obstructed, the epithelial cells that line that tree start to degenerate and they'll release this alk phos, this alkaline phosphatase. It's called liver alkaline phosphatase. And of course it goes up the concentration in the bloodstream. You can use it as a marker for biliary tract obstruction. Also, if the liver is infiltrated with some sort of process that breaks down the biliary tree, maybe a cancer or something, that will also increase the alk phos level from the liver. Okay, any questions about alk phos?
I have a question.
Yes.
About Charcot's triad.
Yes.
What is the triad?
It's it's just above it.
So you're talking about,
So, right upper quadrant pane, jaundice fever,
oh,
okay,
okay,
just above it.
oh, that's that. And then, so the pentad, Raynaud's pentad, is there like a specific symptoms to that? Or is
So you've
that-
got, so the triad can progress to the pentad, so you've got right upper quadrant pain, jaundice, fever, and then you've got septic shock 4 and 5 ultimate mental status, so that's the pentad. Okay. Yes?
The alcohols in this case, is it gonna say anything different than alcohols on the lab, or is it the alcohols?
And there are different ways to order that lab, but generally to discriminate between alk phos bone and alk phos liver, we also order something called GGT. If GGT is elevated, that is that the alk phos is liver alk phos. Okay. There are some other tests that I believe immunologically identify, or maybe by sequence identify either alk phos bone or alk phos liver.
What does GGT stand for?
That's a liver enzyme, it's a transferase. Okay. Any questions on this?
For the acute,
Hmm?
do we know where does the infection begin, or it can be just anywhere along the GI tract?
If you're gonna get an ascending acute infection, it's most likely, at least it's thought, that it starts up here and it will progress upward.
So that is the,
This is the duodenal sweep here.
it starts at the duodenum.
Yeah, so this is the ampulla right here. You can see the pancreatic duct merging in with common bile duct. So presumably the bacteria get up here and they ascend. Now, normally bacteria do get in there, but it's constantly flushed. So if you have any stagnation of bile, like a strictured area might cause, then the system can't flush itself. So bacteria gradually will start to colonize. without being-
So the obstruction occurs first, and then the bacterial.
Right, so you can
infection
have
occurs
maybe a stone that gets caught in here. You can have a pre-existing stricture from another condition, like primary sclerosing cholangitis. So one can lead to the other. The cause might be a strictured area, which can cause an ascending infection, which can cause even more stricture, more scarring. Okay, any questions on that anymore? Okay, so last topic, we're gonna take a look at pancreas. And we're gonna take a look at pancreatitis. There's an acute form of pancreatitis and chronic form of pancreatitis. Acute pancreatitis doesn't present with anything subtle. It's pretty profound. People are bowled over with abdominal pain. Plenty of signs and symptoms associated with acute pancreatitis. Chronic pancreatitis often is indolent, and it doesn't necessarily present with any signs or symptoms until its end stage. So we'll talk about acute pancreatitis first. So you know that the pancreas consists of an endocrine component and an exocrine component. The exocrine component synthesizes enzymes, and as we said in physiology, those enzymes are synthesized in prozyme form, inactive precursor form. They're not activated until they get into the duodenal sweep. So the digestive enzymes that are synthesized, they're not active in the pancreas. They're not supposed to be. Sometimes, though, conditions will be created where those prozymes, those inactive precursor enzymes, are prematurely activated in the pancreas. If that happens, then the pancreas will digest itself. Results in necrosis of the pancreas. You have enzymes that digest the walls of blood vessels, and so you end up with acute inflammation and hemorrhage. And this all culminates in what we call acute hemorrhagic pancreatitis. It's a relatively painful condition. Now we'll talk about why these enzymes might be prematurely activated, but let's just take a look at the acute pancreatitis. Let's first take a look at the normal pancreas. So this is a sculpted dissection of a normal pancreas. Okay, you're actually seeing the tail of the pancreas. The head of the pancreas is over here. The tail of the pancreas is right here. The pancreas has been dissected, so you can see the main pancreatic duct, and this will lead right into the duodenal suite, which is over here. Okay? And then you can see there's some other organ tissues in here, but this is pretty much what the spleen normally the pancreas normally looks like. And you've kind of got that pale gray look to it. Everything looks good there. If this is what a normal pancreas looks like, here is a hemorrhagic, acutely inflamed pancreas. Again, you got the tail over here, and you got the head over here. This pancreas has been sectioned, so you're looking down at the cup surface. And of course, the first thing you notice, it's very erythematous, it's very red, clearly very inflamed. In the head, you'll notice there are pools of blood here. Those pools of blood are the result of enzymes like elastase eating into the blood vessels, causing hemorrhage. And so, all of this is an acute hemorrhagic pancreatitis. Let's take a look at the micro. Let's first take a look at normal. So this is a section through normal pancreas, stained with H&A. And you can see the two components. You can see the acinar component. This is the exocrine component here, consisting of acinar cells. These are all the cells that are going to make the digestive enzymes. You can also see the endocrine component. These are the islet cells here. You also can see a few ducts over here. Those are going to conduct the acinar cell secretions eventually into the main pancreatic duct, and the main pancreatic duct will dump it right into the duodenal suite. Those enzymes should be inactive as long as they're in the pancreas. They should only be activated within the duodenal suite. That's what normal looks like. This is what acute hemorrhagic pancreatitis would look like. There's no normal pancreas here at all. In fact, there's no pancreas, period. It's all been digested. So what we have here is some sort of liquefied material. This is what the pancreas would be. You can see that this area of liquefaction is surrounded by lots of inflammation, and usually this area of liquefaction eventually be enclosed in some fibrous encasement, creating a cystic-like structure we call a pseudocyst. Pseudocyst is just liquefied pancreas surrounded by fibrous tissue. Out here, you can see part of the retroperitoneal cavity. There's a lot of blood here. There's also some peripancreatic fat out here. This is where the pancreas is supposed to be, and it's just nothing but liquid. It's liquefied simply because of all the enzymes having digested. Should digest. Let's have a look at the radiographic appearance of acute pancreatitis. This will allow you to appreciate just how inflamed the pancreas is. Here is a normal pancreas, so CT scan, anterior, posterior, right and left, normal liver, normal spleen. There's some oral contrast in the stomach, descending aorta here. And of course you can see, there's the pancreas. This is the head, and there's the tail. take a look at the size of the pancreas compared to the vertebral column for scale. Okay, everything looks good there. Okay. Note the radiographic appearance, it's got that salt and pepper texture to it. Okay, again, normal pancreas. And if that's normal, this is not normal. This is acute pancreatitis. We're a little lower in the abdominal cavity. And of course, vertebral column is here for comparison. And you can see incredibly swollen pancreas. There's the head, there's the tail. Not only is it large, but you'll notice the radiographic texture isn't normal at all. You can see these lucent areas, these radiodense areas. These lucent areas are probably remarkable for edema. It's just so incredibly inflamed. You can see how large it is. And there's nothing subtle about acute pancreatitis. Okay. Well, sometimes you can get this under control. The pancreas inflammation could resolve, but there are going to be areas of damage to the pancreas. Areas of the pancreas will be liquefied. Sometimes that area of liquefaction will be closed off by a fibrous enclosure, and what ultimately forms is something called a pseudocyst. A pseudocyst is just a part of liquefied pancreas surrounded by fibrous tissue created by the inflammation. This is what a pseudocyst looks like. So this is someone post-acute pancreatitis. And again, we're at the level of the kidneys here, vertebral column for scale. This whole thing is the pancreas. You've got the head right over here. This is the tail. If you look in the tail, you can see there's this kind of homogeneous area here that's surrounded by something a little more radiodense. This is a pseudocyst. This is an area of liquefied material, and it's enclosed by some sort of fibrous encapsulation. Sometimes these pseudocysts will grow over time. The remaining normal pancreas sometimes will feed the cyst with little pancreatic ducts in which their pancreatic secretions start to accumulate. And so something like this, very often you have to drain. You can do it percutaneously. You can put a needle here and drain the cyst. Okay? The cyst might recur. You might have to get in and cauterize some of the ducts and seal them off so that the cyst does not form again. But this is one of the many sequelae of acute pancreatitis. Okay. Questions on that so far?
Is there an age range for this?
There are risk factors, each of which has its own age range. So let's take a look at some of the risk factors. Biggest risk factor would be gallstones and alcohol. Alcohol and cholelithiasis accounts for 80% of the cases of acute pancreatitis. And generally speaking, if someone who is presenting with acute pancreatitis is clearly not an alcoholic, the next thing you'd probably do is work them up for gallstones. Chances are one of those two things is responsible. But there are other things you might have in the history that lead you to believe might be the cause: hyperlipidemias, hypertriglyceridemias, some certain types of infections, mumps virus, uremias. All of those might be causes of acute pancreatitis. So if you have someone, for example, who's got chronic renal failure, they're not alcoholic, they don't have gallstones, you might think, well, maybe their blood urea nitrogen is really high, and that's what caused it. And they might have other signs and symptoms of uremia. Maybe that or pericarditis at the same time. That would give you good context. Okay. Any questions on that so far? Alright, let's take a look at what could possibly activate these pancreatic enzymes prematurely. So let's look at some rough categories, and we'll look at the molecular mechanisms behind it first. So these are some of the common causes of prematurely activating those prozymes in the pancreas. So sometimes they're metabolic, mechanical, vascular, and infectious, some of which I just mentioned. So again, look at the top list. Metabolic would be alcoholism. We'll talk about how that works. Okay. Mechanical, gallstones, again, right at the top of the list. Vascular, shock. I'll show you that some of the acinar cells will degenerate and they'll release their enzymes. And when they release their enzymes, they become prematurely activated. And then, of course, we have infectious mumps and coxsackie virus. All right, let's take a closer look at the causes of these things, the basic mechanics of these things. So many conditions can actually predispose one to developing acute pancreatitis. But when you look at all of the different causes of acute pancreatitis, usually what prematurely activates those enzymes is one or more of these three mechanisms shown here. You have duct obstruction, direct acinar cell injury, or intracellular acinar cell transport defects. So let's take a look at the duct obstruction, the easiest one to understand. So we have, again, the depiction of the pancreas here, the main pancreatic merging with the common bile duct going into the duodenal sweep here. Say you have some gallstones or lithosis, usually it's gonna get caught right there at the ampulla, and it's gonna block the common bile duct as well as the main pancreatic duct at the same time. Once that duct is obstructed, pressure is going to back up along the main pancreatic duct, and that's going to result in some interstitial edema. The interstitial edema could collapse the local vascular flow. That will result in ischemia. The acinar cells will begin to degenerate. The acinar cells, when they degenerate, will release their enzymes, and those enzymes will start mixing with lysosomal enzymes. The lysosomal enzymes will cleave and activate the digestive enzymes. So the lysosomal enzymes mixing in with the digestive enzymes, that's what activates the enzymes. And you have a number of different enzymes that are going to be activated. Proteases, of course, break down the proteases. The lipases and phospholipases that's going to cause enzymatic fat necrosis. And you've got elastase breaking into the blood vessel walls, resulting in hemorrhage. And all of that's going to culminate in acute pancreatitis. Okay. Let's take a look at some of these other mechanisms. So that's just one of three mechanisms. Again, you could have direct acinar cell injury. Alcohol can work in this respect. Alcohol can directly damage the acinar cells. Again, trauma, ischemia, viruses, those can all be responsible for directly damaging the acinar cells. Same thing happens. You get the release of the prozymes and the lysosomal enzymes mixing together. The lysosomal enzymes activate the prozymes. And again, all of this will culminate into acute pancreatitis. Another thing that can happen, you get this intracellular transport defect that develops. This can be caused by things like alcoholism. As a result of defective intracellular transport, sometimes prozymes and lysosomal enzymes are delivered to the same compartment. They never should be. They should always go to different compartments, but sometimes as a result of defective intracellular transport, lysosomal enzymes and pancreatic enzymes mix together. So normally what happens is that we have most of these enzymes, both lysosomal and digestive enzymes, being synthesized on the rough endoplasmic reticulum. Then they'll go to the Golgi apparatus for post-translational modification, after which time the digestive enzymes should go to the zymogen granules and should be stored there in inactive form. Also, The lysosomal enzymes that are synthesized, they should be brought to the lysosomes, okay? And the lysozymes should remain in the lysosomes. And again, these different enzymes never should mix, but as a result of some metabolic disruption, perhaps caused by alcohol, instead of the prozymes going to the zymogen granules and the lysosomal enzymes going to the lysosomes, sometimes these prozymes are all dumped into the lysosomes along with the lysosomal enzymes. The lysosomal enzymes will cleave and activate the prozymes. And so again, you have premature activation, all of which culminates again in acute pancreatitis. So there are many different things that can cause acute pancreatitis, but the ultimate mechanism of activation of those prozymes is usually one or more of these three possibilities. Okay, so let's talk about presentation. So again, I mentioned acute pancreatitis is not solved. Acute abdominal pain, usually patients will complain of abdominal pain that kind of drills to their back, and often it's somewhat alleviating of the pain as people lean forward a bit. So you might find the patient is on all fours when they have acute pancreatitis. Okay? Biggest problems, you've got hemorrhage and the release of massive vasodilatory agents. That can cause shock. Markers for acute pancreatitis include pancreatic amylase and lipase. Usually if you measure those collectively and you find that they're elevated, they're sensitive and specific for acute pancreatitis. And I want to emphasize, those are markers for acute pancreatitis, not chronic pancreatitis. They don't work for chronic pancreatitis. But if they're elevated, amylase and lipase, they are good markers for acute pancreatitis. I mentioned before that there are lipases and phospholipases that are activated that can digest the fat in the abdominal cavity. When fat is digested, ultimately what's liberated are negatively charged fatty acids. The negatively charged fatty acids will complex with calcium. And those fatty acids will get the